is Neuro-Ophthalmologic. Okay. And I think you guys are studying vision this week. And so this is a huge topic. And I've got a typo right here on the front page. Over 1/2 of the brain is involved in processing of visual information. Now, only about 10% is devoted solely to vision and nothing else. But regardless, with over half of the brain being involved in vision processing, clearly vision is very important as far as the brain's priorities and our needs as far as functioning as humans. This is a very complicated, huge topic, and we're only going to be able to touch on just some very specific common conditions. We're going to be focusing on things that you typically see in the pediatric population, so staying away from a lot of the specific stroke syndromes that you see in adults that even in pediatric strokes we don't tend to see because they tend to be watershed strokes. We're not going to be really touching on that type of thing. I'm going to be focusing on two different things that we tend to see fairly often. And it's going to be vision loss, and specifically looking at optic neuritis and pseudotumor. And I know all of y'all are really familiar with seeing a lot of this. And then some common causes of double vision, and specifically myasthenia gravis and some of the cranial nerve palsies. Very much because with some of the cranial nerve palsies, one of them you see very often with pseudotumor, and it can really be kind of a marker that, hey, we've got intracranial pressure, increased intracranial pressure here. And with the other ones, because some of the causes are things that we really need to deal with urgently and evaluate quickly. Certainly with either of these complaints, vision loss or double vision, there can be solely ophthalmologic reasons behind it. However, these are things that can have a neuro reason behind it. And so we're often involved. So we see optic neuritis pretty commonly in the hospital. You know, a kid comes in with fairly acute onset loss of vision, typically in one eye. Occasionally it can be bilaterally. And sometimes this can occur in isolation. And these are the kids that tend to do much better, and that, you know, we treat them, which we'll go into the details of later, and they do well and typically don't have recurrences. However, we can also see it associated with other diseases. So it can be a part of neuromyelitis optica, hence the optica. It can be a part of anti-MOG disease and in multiple sclerosis. In fact, optic neuritis is often a presenting sign with multiple sclerosis. And then less frequently, it can be a part of some infections, including Lyme disease, which of course can do anything. It can be a side effect of some drugs, particularly TB drugs, and then some systemic illnesses such as sarcoidosis and lupus that we see really commonly, but not often with optic neuritis, but they're such common diseases that we see it commonly. With optic neuritis, basically what it is the optic nerve is inflamed and it's swollen, and that's what's causing the visual symptoms and the changes that we see on exam. Typically, the loss of vision is pretty quick. It isn't instantaneous, but it tends to be over hours or days. And sometimes people can wake up and they were seeing fine last night and now they can't. It's usually unilateral. About 10% of the time it can be bilateral though, so that doesn't rule it out as an etiology. And it can follow multiple different patterns of vision loss depending on sort of how the swelling starts off and progresses. So the very classic presentation is a central scotoma, where you lose right in the center. However, you can have full visual loss, you can have peripheral vision loss. We had a kid admitted a couple of months back who had more of it was a hemivision loss, the top two quadrants of her vision just completely gone, and then it progressed to full. You can have loss of vision, of color vision as well. In fact, that's probably going to be the first sign, but no one really picks up on it. And the color red is probably the one that really picks up the most. And even after you recover, loss of just really bright red perception may be one of the really lingering signs. You also can lose contrast, which is going to affect your night vision. And sometimes this loss of vision can also occur with flickering lights in the eyes. This is maybe like 25% of patients, maybe 20, 25. You also are going to have pain, and it's often worsened by eye movement. And it's often described as a dull ache, but sometimes it can be sharp as well. Typically, it's pain kind of right behind the eye. So with optic neuritis, you're going to see decreased visual acuity. So if you do a vision test, depending on whether or not they have central or peripheral vision loss, you may be able to pick it up just with your basic card test. You have decreased red perception. So you'll see lots of times the ophthalmologists carry around red objects, and they'll get people to look at it with the affected eye and with the unaffected eye. And oftentimes it may be something that they haven't even noticed, but it's definitely a duller red with the affected eye. There's the pain with the eye movement on exam. And then you can have an afferent pupillary defect. Not always, but many times you can see this. And so what's going on with that is you do the exam, and normally you swing your light into one eye, and you not only have constriction of that eye, but constriction of the other eye, and then you switch it over to the other eye, and the same thing happens. So whenever you have the afferent pupillary defect, whenever you shine the light into the unaffected eye, both eyes constrict. However, when you shine it into the affected eye, not only does that eye not constrict, but the other one doesn't either. And what you often see is that it kind of expands a little bit if you swing it fast enough. And so that's your afferent pupillary defect. Also, if you're able to get the patient to cooperate with a fundoscopic exam, you may see optic disc blurring from the optic nerve head edema. And this is, of course, difficult for us to do because unlike the ophthalmologist, we don't have those great drops. We try our best, and I'd say, I don't know, it depends on the age of the patient, but I have mixed luck getting them to cooperate. If I can see a sharp disc, I feel fairly confident, but if I just see a blur, it's kind of hard to tell, was it a blur because I didn't get a good look at it many times versus is there something actually, is it actual swelling? Regardless, if this is a concern, I get ophthalmology involved, get them to do their drops so we can have a really good dilated exam. So this is what you'd see basically on your fundoscopic exam. If it's normal, it's going to be very crisp, very sharp. And if you're seeing edema, it's going to be blurred. And you've got to have a very good visualization of that disc to really see it. You know, it's not enough just to see the color change. You've got to see it, and you've got to see it. They've got to keep their eye still enough for you to kind of appreciate the crispness of it, which is almost never going to happen in a small child and can be really difficult, especially if someone's really in pain with the exam and just really worried and not feeling up to cooperating. So, you know, definitely try, but this is definitely one of the more difficult parts of the neurological exam. So workup, if we're concerned about this, we're going to want to get an MRI of the brain and the orbits. We're going to want to get it with contrast, and we're going to be looking for acute demyelination and inflammation, not only of the optic nerve, but we're also going to be looking for evidence that there may be lesions somewhere else in the brain. If the patient has any sort of spinal cord complaints, and we're thinking potentially neuromyelitis optica, we may get spinal imaging, particularly of the C-spine. What we're looking for with MRI of the brain is evidence of lesions suggesting MS, because if you see optic neuritis and you also see areas of prior demyelinating illness, that patient, even if they haven't had symptoms that they were aware of, is at much higher risk of proceeding on to MS than if it's an isolated optic neuritis, the brain itself looks totally clear. And then, of course, if they're having any sort of spinal cord complaints, getting at least cervical spine imaging, maybe full spine. An LP is not necessary to make the diagnosis. Many times we get it, though, to send for IgG and oligoclonal bands so that we can test for likelihood for MS. So that can be useful if that's a concern, but it doesn't really change the optic neuritis workup per se, just a comorbidity testing. And then you also want to test for etiologies. You want to look for other diseases. So often we'll send testing for aquaporin 4 for NMO. We'll send anti-MOG antibody for the anti-MOG disease. And, if you're concerned about lupus, sending ANA and all of that workup, if infectious diseases, sending Lyme titers, whatever kind of corresponds to your concerns as far as a workup for systemic disease. And some of this workup can potentially be done later as well. So complications of optic neuritis. Clearly, we're going to be worried about permanent optic nerve damage. Oftentimes, particularly if you have an isolated case of optic neuritis, no other disease, a person is going to have recovery of most of their vision on their own gradually over weeks to months. We certainly want to treat because it certainly seems to speed recovery, and it may ultimately improve recovery. So the treatment is generally IV methylprednisolone, followed by an oral prednisone taper. And then if the optic neuritis is refractory, considering using Plex. IVIG really has not been studied with optic neuritis. There have been case reports looking at the possibility of it. Overall, the evidence seems to support Plex, though, as a second step as opposed to IVIG. Clearly, in the peds community, there may be a little bit of an issue depending on age, and you just have to do what's right in any given circumstance. So going on to pseudotumor, we see this, and we see even more patients that we're concerned about this with. So pseudotumor, also known as idiopathic intracranial hypertension, is when you have increased pressure inside the skull, and there's no clear reason behind why this is happening. And the thought is that you're probably not absorbing your cerebral spinal fluid as much as you're producing it, and that it's probably some sort of problem per se with absorption. It mimics the symptoms of brain tumor, hence the pseudotumor cerebri. The increased pressure causes swelling of the optic nerve, and this swelling is what causes the decreased vision. This can be a much more gradual loss of vision than what is seen with optic neuritis. It can take place over weeks. And very often people have other presenting complaints. So headaches, of course, are one of the more common things that people come in with it. You can have nausea and vomiting with the headache, or separate from the headache. You can have dizziness, and you can also have a cranial nerve 6 palsy. And so someone coming in complaining of a headache and blurry vision, and you notice that they have a cranial nerve 6 palsy, and it could be bilateral, but it could be unilateral, you're really going to think, oh, wow, this may be pseudotumor. Oftentimes, in addition to the headache itself, people also complain of pain in the neck, the back, the shoulders. I don't entirely know why, but they often do, and sometimes they consider that to be a worse pain than the headache itself. The vision loss is often peripheral first, and then kind of increasing to potentially encompass all vision. And there's also an increase in the size of the blind spot, which makes sense because the optic nerve is swelling. Generally, people don't complain of that. That's something that you find on exam. And often, because it affects the peripheral before the central, your basic vision tests that you do in the emergency department or on admission probably aren't going to pick it up. You're going to need a visual field test done by ophthalmology to really be able to pick up on it, unless it's pretty late stage often. The headache itself is often the first thing that people notice, and sometimes can bring them to attention before there's any visual loss at all. It's usually a daily or near daily headache that's just kind of always in the background. The pain is variable, but people often complain of it either being behind the eyes or in the back of the head. It's often worse lying down, which makes sense, and it may be associated with vomiting. So of course, the lying down, making it worse, and the vomiting are going to be triggers for you to think, oh, this might be a dangerous headache. Risk factors, they love to test on this: obesity, women in their childbearing years, medications, specifically growth hormone, acne medications, including retinols and tetracycline, lithium, and then withdrawing from steroids can also increase intracranial pressure, probably because the steroids themselves decrease intracranial pressure. Other diseases that are associated with a much increased risk of having pseudotumor: lupus, PCOS, sleep apnea, hypothyroidism, Addison's disease, hypoparathyroidism. On exam, you're going to be looking for papilledema, and unlike before with the optic nerve, optic neuritis, more often than not, you're going to see bilateral papilledema. Occasionally, you can see it unilateral, but it makes sense that generally this effect is going to be bilateral. The complications, the big one, of course, is going to be vision loss, leading ultimately to blindness if it's a really, really severe case. But also the headaches tend to be debilitating. The nausea, the dizziness can really interfere with quality of life. And many times people are going to come to attention through the emergency department or your clinics well before they start having massive levels of vision changes. So your workup exam your workup is going to include an eye exam, but like we said before, your very basic eye exam probably isn't going to pick it up unless it's been going on for a while or is really rapidly progressive. You're going to need to get ophthalmology to do the visual field testing. You're going to want to do imaging of the brain before you go to LP. Not only does that assess for an intracranial mass, which has symptoms very similar to a pseudotumor, but if you have a mass that's obstructing the ventricles, you could have an increased risk of herniation with an LP. Nobody wants that. So get the imaging first. If you get imaging of the orbits, you may also be able to appreciate papilledema on it. I've really not seen a case where you could appreciate papilledema on the imaging and not on the exam itself, but the exam, of course, can be difficult. If you have concern for venous sinus thrombosis, which can increase intracranial pressure, you may want to get an MRV. Because this would have a cause, this would not be pseudotumor, but other than the fact that you've got this giant clot in the venous sinus, it can present exactly the same. So if there's any risk for that, get an MRV when you're getting the MRI. And then once you've ruled out any sort of space occupying mass that may be blocking the ventricles, you can get a lumbar puncture with opening pressure. That's going to be diagnostic. It's also going to help treat a little bit, at least short term. You also want to assess for offending drugs and, of course, comorbidities that might be able to explain. So treatment, part of that's the lumbar puncture. You're going to be able to decrease the opening pressure, or from opening pressure to closing pressure, you'll be able to decrease it to normal. Very often, the headache goes away almost immediately. Unlike your typical LP, people feel better afterwards generally. And then many times, almost always, we start people on a medication like acetazolamide. The brand name is Diamox, and this helps as far as reducing CSF production just very slightly, but since it's just a slight imbalance, many times that can be very helpful. Diamox can make people feel bad. We often start them at sort of low moderate dose, and sometimes we have to go up from there, and it's going to be really helpful when you're monitoring long term to have ophthalmology help you, particularly if people don't have headaches with it, which more often than not, people do have headaches, but we've really had a run recently of kids that have had clear pseudotumor without any headache at all. And, you know, how do you monitor otherwise unless you have ophthalmology involved helping you monitor for improvement in the optic disc swelling? You're going to want to recommend lifestyle modifications as appropriate. Clearly, if they're on any of the offending medications, you're going to want to get them off of that. If obese, weight loss, even a small amount of weight loss can help. Sometimes if the headache is really refractory, we add on diuretics, which can, by causing fluid loss, can help with the overall severity of the headache. We can also sometimes add on migraine medications, particularly if it's a mixed type headache, and that can help a little bit. If it's really, really refractory and we're concerned for losing vision, they may be referred for optic nerve sheath fenestration. In some really advanced cases, people have actually placed shunts, like a VP shunt or venous sinus stenting. Clearly, these are worst case scenario type treatments. I've never had any people personally, at least so far, that have had to go that route. Generally, I think that probably happens more often in adults, but certainly you're not going to want to risk losing vision. So common causes of neurologic double vision. So the first thing to determine whenever someone's coming in complaining of double vision is it monocular or binocular? So does the double vision go away if you close one eye? And if it doesn't go away when you close one eye, then this is not a neurologic condition. It's either ophthalmologic and due to some sort of refractory error, or it's a psychiatric complaint. But if it goes away whenever the patient closes an eye, it may very well be neurologic. And binocular double vision is generally caused when it's neurologic by a misalignment of the eyes. And this can be due to either cranial nerve palsies or weaknesses that are asymmetric. And neurologic diseases can sometimes cause this asymmetric weakness of the muscles around the eye. So with myasthenia gravis, as you're familiar, this is an autoimmune disease with antibodies to acetylcholine receptors, and it causes fluctuating weakness in patients. And this weakness presents itself most prominently as fatigability. So the symptoms get worse as the day progresses, or if they exert an extreme amount of effort. Myasthenia gravis very often presents first in the eyes, and occasionally in a small proportion of patients, it stays within the eye and doesn't progress throughout the body, and it's called ocular myasthenia gravis. But almost around half of all patients, the first symptoms are going to be vision, even if it does spread elsewhere. So the vision loss can be due to misaligned eyes because of the asymmetry and how it affects the muscles surrounding the eye, leading to misalignment of the two eyes. It can affect, it can cause double vision. It can also cause difficulty focusing due to difficulty converging on an object. Also, another thing that can affect vision with myasthenia is the drooping eyelid, which isn't going to cause double vision, but can be a problem nonetheless. And so one of the things that can make things difficult, especially as far as treatment goes, is that the double vision does fluctuate. You're going to see progression throughout the day, progression with effort. So the more someone's trying to read, the more they may have difficulty converging and focusing. And the specific asymmetry is going to vary from patient to patient, and it can vary also with the course of the disease. Eye patches tend to help. It's due to the two eyes being misaligned. So patching up one eye, particularly if one eye is weaker than the other, could be of use in helping someone read or function. Prisms are very helpful. This isn't something a neurologist would do. This would be ophthalmology, but ophthalmologists can prescribe prisms, which can help with the double vision. However, because of the fluctuations that are inherent with myasthenia gravis, it tends to be a lot harder than people who just have eyes that are misaligned just at baseline due to a steady weakness and asymmetry. And then, of course, controlling myasthenia overall is going to be helpful in improving the visual symptoms. So cranial nerve palsies. Cranial nerve 6 palsy, as we were already discussing, very often seen with pseudotumor. So cranial nerve 6, our abducens nerve, it innervates the ipsilateral lateral rectus muscle. It also partially innervates the contralateral medial rectus muscle through the medial longitudinal fasciculus, but focus mainly on this ipsilateral lateral rectus muscle. So the eye is not going to be able to fully abduct. And this is going to really be noticeable whenever when you're looking towards the affected eye. However, whenever you're looking straight ahead, you're also going to see it a little bit. And because it's going to be the least noticeable when you're looking away, people may turn their head to compensate. And by turning your head over to the side, this can make the double vision go away or at least lessen. And so you can see with this gentleman at rest, you can see that that left eye is kind of drifting in. Whenever he looks over to his right, you're seeing not much asymmetry at this point. And then whenever he looks over to the left, over to the affected side, you're really seeing that asymmetry jump out. But even at baseline, you can see that left eye is just kind of shifting in a little bit. So the abducens nerve comes off of the pons, and so it's leaving the brain stem at a lower point than the other eye muscles. It's running through the floor of the skull to reach the cavernous sinus, and it isn't clear why, but something about the position of this sixth cranial nerve makes it more sensitive to increased intracranial pressure. So if someone's coming in with pseudotumor or some other reason for having increased intracranial pressure, that tends to be the nerve that if anything's going to get pinched, you're going to see. Exactly why that is, there's not like one specific location that it's most likely to get pinched at, but it has something to do with that. Anytime you're worried about a cranial nerve palsy, keep in mind that pseudotumor might be a common cause, but workup should include an MRI of the brain and the orbits regardless, because there can be other causes, including masses, trauma, that sort of thing. A cranial nerve 3 palsy is incredibly dramatic. So looking at someone, you're going to be able to tell very obviously that something is going on with control of the eyes. It's not going to involve just the eyeball positioning, but the eyelid as well, and potentially the pupil. So the oculomotor nerve innervates the superior, middle, inferior recti, and inferior oblique. The only eye muscles that are still going to be functioning if you have it lesioned are going to be the abducens and the superior oblique muscles. So if you have a cranial nerve 3 lesion, your eye is going to be down and out. In addition to innervating the muscles of the eye, it also innervates the levator palpebrae. So you're going to have eyelid ptosis. It also, running along the outside of the nerve itself, are parasympathetic fibers from the Edinger-Westphal nucleus. And so a lesion can affect the parasympathetic fibers, which are innervating the constrictor fibers of the pupil, and you end up with a blown pupil. So here are some pictures. And so you can see just baseline, that person looking at you, you're going to notice, wow, the eyelid is droopy, the eye is pointing down and out. If you're moving the eyes around, it's going to be difficult to fully compensate. However, you may see less misalignment looking toward, because that eye is down and out. So looking toward and down is probably going to decrease the symptoms. You'll also be looking for the pupil size, whether or not it's blown. We'll get into why that's important later. So in adults, most third nerve palsies are due to ischemic strokes, due to chronic health conditions. This really isn't the case with kids. With children, there's a high risk that it's due to an aneurysm. I mean, this can happen in an adult as well, but it's more likely to be an aneurysm pressing on the nerve. And also other mass lesions like tumors can cause a third nerve palsy. So one thing to know, and one of the reasons you're going to want to assess for that pupil being blown, is because the sympathetic or the parasympathetic fibers travel on the outside of the nerve. And so if you have pressure on the nerve, it's more likely to affect these parasympathetic fibers and to have a blown pupil. Whereas if you have an ischemic lesion, it's less likely to affect it. So having a blown pupil is going to tell you there's more likely to be something pressing on the nerve, either a tumor or an aneurysm. Either way, something you definitely want to look into, because things may get worse as opposed to just being a static injury. So workup should include MRI of the brain, but if there's a blown pupil, also get arterial imaging because you're going to be worried about an aneurysm. So cranial nerve 4 palsy. This one is really subtle. It's kind of hard to pick up on, even if you know what you're looking for. It affects the trochlear nerve, which innervates the superior oblique muscle. The superior oblique, if you can remember back to medical school, acts on a pulley. And so it moves the eye down, and it also kind of twists the eye inward. And so if there's a lesion to the cranial, the fourth cranial nerve, the patient is going to have a slight upward deviation of the eye, and also going to have a twisting of the eye outward. And so to decrease the double vision, to compensate, the patient may tilt their head away from the lesion side to kind of line things up. And one of the things, and which kind of makes sense when you think, okay, the eye is twisted and it's going up, is that these patients tend to really report difficulty going downstairs. That's when they tend to have the most problems. And so this is just showing how with the lesion, you're going to have that twist. You're going to have that alteration in the eye, and how if you tilt your head, you can kind of compensate for it. And so this is just another one showing how if you twist, you can kind of compensate for it. And so you may notice people's head tilting. And because it's not going to have as much of a profound effect on the eye alignment when someone's looking straight ahead. And in this one, if you look at B, the person's eye is up, but in real life, it's rather subtle. One of the biggest indicators may be the fact that the person's kind of tilting their head over. And really prefers to maintain it without sometimes even consciously knowing they're really doing it. And then this is just showing the person moving their eyes around and just the different ways of compensating for it. So cranial nerve for palsies. The cranial nerve 4 has the longest distance inside the cranial vault, and it's also the skinniest nerve. So it's the most injury prone due to anything other than increased intracranial pressure, which affects the 6th nerve for reasons we don't quite understand. There's also a fairly high proportion of people who have a congenital issue where the nerve itself is hypoplastic, and then over time there's decompensation and the nerve gets smaller and the muscle gets weaker as a result. In children, your most likely cause is going to be congenital. The second most likely cause is going to be trauma. In adults, ischemic injury is incredibly common, but in children, you're going to be thinking, is this something congenital that has kind of progressed over time? And if it's acute trauma, tumors can also always be a possibility. An MRI of the brain is going to be your first step in workup. And so we have a list of the different cranial nerve palsies here. Things to remember: third nerve palsy going to be really apparent. You're going to have that eyelid involvement as well. You're going to look for the pupil being dilated. Fourth nerve palsy going to be really subtle. One of your best clues that it's going on is going to be tilting that head over to the side to kind of compensate for the twisting, torsion, and upward deviation of the eye. And then cranial nerve 6 palsy, you're going to be thinking increased intracranial pressure is a likelihood. Looking over to the side may decrease the visual symptoms, so you may notice the person turning their head away from you. There are many other neuro-ophthalmologic issues. Clearly, we don't have time to discuss all of them. Nystagmus, of course, is often related to vestibular issues. It's important to look at the quality of the pursuits of the eyes. There are just tons of things that you can discuss, but I think these are the things that you're probably going to run into most often when you have to think quickly and come up with a workup. With many other things, there's at least a little bit of time to kind of think about it, or the eye movements are so abnormal that you're going to say, yeah, we definitely need to get imaging, like opsoclonus, myoclonus, something along those lines. Nothing subtle about it. So these are probably the most common things you're going to see, and the things that you're going to have to make a decision about, do we need to get neuro involved? As far as a summary, very common causes of double vision are going to be myasthenia gravis in children. It's going to be cranial nerve palsies. Common causes of decreased vision due to neuro-ophthalmologic causes. Clearly, we're not focusing on ophthalmologic causes, which are going to be your most common cause of decreases in vision, is going to be optic neuritis and pseudotumor. Optic neuritis can happen rather fast. Pseudotumor is going to be a little bit slower. This was as much as I could abbreviate it. So let me know if you have any questions. eye exams are tricky. You gotta, particularly with kids, because you've got to have some cooperation on their part. Particularly if you're trying to get a fundoscopic exam, but even getting range of motion. If something's making a child feel bad, they're not really going to want to move their eyes around, not just with pain, but because dizziness doesn't feel good. And you're going to have more double vision and more disequilibrium when you're making them move their eyes around. So, you know, you do the best you can, but these can be tough. So does anybody have any questions? Well, as far as references, eye movements, bizarre eye movements can be really tricky. It's good to have a few things that you can look at textbook wise. Lee and Z's The Neurology of Eye Movements is really great for looking specifically at neuro-ophthalmologic disorders, and I think it's really approachable. Clinical Neuro-Ophthalmology by Walsh and Hoyt is also pretty good. I use the Principles of Neuroscience just for some of the basic science stuff. And then Tim Root is an ophthalmologist. I think he's down in Florida. He makes a lot of weird cartoons and videos on ophthalmologic issues, which are surprisingly helpful. So it's worth looking into if you're stoked about something. And he also has a really good way of like visualizing things so that you understand. And sometimes reading written descriptions of abnormal eye movements, it's hard to appreciate what people are talking about. So if you guys don't have any questions, I will let you go for today. But, you know, always grab us if you have any concerns. We often drag ophthalmology into it as well because they can get really good exams. They also have a lot of tools at their disposal like OCT and such that can really help as far as visualizing to help the retina. But yeah, just let me know if you have any concerns and we'll talk to you guys later.